My name is Mary Moriarty. I'm the Hennepin County Attorney. That means Minneapolis and its suburbs. I've just finished the second year of my first term. I participated in a call with other prosecutors across the country where one of the topics was criminalization of pregnancy. And I actually didn't think that topic was going to be very relevant here to us in Minnesota. But then I heard the experts talk about prosecutors' offices that charge pregnant people for using drugs while they're pregnant. And so I wondered whether that was something that we did. Often our office was charging the pregnant person with child endangerment. We were sending those cases by and large to diversion, so they were not going to jail or prison. But what I realized at the time, and this is something that was discussed at that meeting, was that just the idea that a pregnant person could face criminal charges was preventing pregnant people from seeking prenatal care because they were afraid that they would be criminalized. So when a pregnant person avoids getting the medical attention, the prenatal medical attention they need, they're much more likely to overdose. They're more likely to not seek treatment, which would help them. And their children weren't going to get prenatal care that they needed. The other big consequence was that there was a risk, or even a perceived risk, that your child might be taken away from you when the child was born. We know outcomes for children who are not allowed to stay with their parent are worse. In fact, the more I've gotten into this job, the more I see when children come into the system, our juvenile justice system, or even as emerging adults, when I look at their history, I can see there's a history of foster care, of trauma, of being separated from a loving adult. So I think if we look at this very broadly, we can see that these kinds of policies that would scare pregnant people from getting medical attention actually could lead to more involvement in the system by their children. So we looked at our policy and we worked very hard and ultimately came up with a blanket policy. There are no exceptions on this, that we would not charge people who were pregnant who were using drugs during pregnancy. And that was really important because if you have exceptions in the policy, it isn't helpful because people still think they might be charged. Also, I think for some people, they thought, hey, the idea of potentially being charged would deter people from using drugs. And when they would find out, no, it's actually the opposite. And for many people here who already know that addiction is an illness, a disease, it made sense to them that just because you criminalize something doesn't mean that a person who's struggling with addiction is going to be able to stop using. So it's been relatively well accepted here. And I think much of it was really the messaging behind why we are doing this and why this is a good thing for children and pregnant people. So in the scheme of things, I think law enforcement here understands this is actually a public health approach, and certainly about public safety, because if you can keep kids in a healthy environment and their parent in a healthy environment, they are much less likely to become involved in the system or come to the attention of police. And my hope is then that there are cases where that child is not taken away, is left with their parent and able to bond with the parent, and that will provide for much better outcomes when you look into the future of that child's life.
My name is Dinah Ortiz Adames. I'm better known as Dinah Ortiz. I'm a drug user human rights activist for over 25 plus years. Jail is not a place where you're supposed to have a child, where you're supposed to give birth. It just isn't. It's not like you could keep your baby there with you. It's not like you could nurture your baby. It's not, like you give birth in shackles and handcuffs, and then they take the baby away. Anyone who is pregnant and about to give birth should be released to give birth and to spend that time with their family or their support network or whomever. Because that's a real kind of like whirlwind of a time and roller coaster of a time. The shame that I had because I had used while I was pregnant, doctors that had screamed me out of their office, when they found out that I was an active user, the stigma, imposed on me from my family, and because I was facing prison time. So I literally knew that I was going to have to, pass my daughter over and go to prison. So it was a really hard time for me, but what made it easier a little bit was that I was able to give birth in the free world. There has to be some sort of harm reduction involved. Harm reduction is going to the OBGYN, right? And being able to get, whatever reproductive health services that you need in order to like make sure that you don't get sick or make sure that you are not unhealthy, and that you are getting all of the medical and health services and healthcare that you're, that is your right to receive. And why is there punishment, right, for somebody who uses drugs? And it's always someone who is, poor, right, and marginalized that gets penalized. As we know, affluent, people who use drugs don't experience any of the things that we do. If it works, that they are not involved in their lives, then it should work equally for us and my community, right? Law enforcement has no place in medical care, because there is like this fear mongering that happens whenever law enforcement gets involved. We say that drug use is a health issue, but it's the only health issue that we penalize folks for. So we have to make up our minds. Either it's a health concern or a health issue, or it is something that we're going to penalize and arrest folks for. It can't be both, and it absolutely should be, fall under the healthcare bracket, right? Because, people use drugs for all kinds of reasons. It should always be that person's decision, and as long as they're not harming or hurting the people around them, then it's nobody's business. But if they want to be open and transparent with their medical provider, they should have that option without being afraid of being penalized.
I'm Mishka Turplin. I'm a physician. I was trained as an obstetrician gynecologist, and I'm also boarded in addiction medicine. And I've really worked at the intersections of reproductive and behavioral health for 20 or 25 years. So when I was a medical student in the 1990s, we almost never drug tested somebody during the birthing hospitalization and never reported anybody to child welfare for having a substance exposed newborn. So my familiarity or my experience of pregnancy criminalization really came from following my patients as they began to get reported, as the state statutes changed, as people started over-testing, and really following them from clinic first into family court. And then over the last several years, as I've gotten more involved in legal cases, becoming involved in criminal cases. So when I was in training, there was like much less pregnancy criminalization than there is today. I think the biggest misconception related to substance use in pregnancy is that infants who are prenatally substance exposed are doomed, that the exposure is going to have some catastrophic consequence on their development. We actually have decades of data, the prospective cohorts, cross-sectional studies, all sorts of evidence that evaluates what the effect of the in utero chemical exposure to a particular substance is on child development. And overwhelmingly, like the magnitude of the effect is either absent or very minimal and much, much smaller than the importance of the caregiving environment. So one of the big misconceptions, I would frame it as, we overstate the importance of the in utero exposure and really minimize the importance of the caregiving environment. We have known how to care for pregnant people with substance use disorder for 50 to 60 years. There are some new medications that have become available in the last half century, but really the principles of care have remained constant. But despite knowing how to care for folks with addiction in pregnancy, the big gap is one of implementation. Most people with a substance use disorder do not receive treatment, much less evidence-based or person-centered treatment during pregnancy or like while parenting. About 80 to 90% of people with a major depressive disorder or diabetes or hypertension report receipt of any treatment in the past year. For substance use disorder, that number's around 11%. In pregnancy, it's slightly higher, but it's still something between 15 to 20% of people with an addiction in pregnancy receive any treatment, a number that's much smaller than other chronic conditions. So the biggest gap isn't a knowledge gap or a science gap, it's an implementation gap. We know what to do, we know how to care for people, but they do not receive care. And that's to a large extent because care just doesn't exist. And when it does exist, it's criminalized or it's notified to child welfare, and that's a huge barrier for people to obtain like the rare care that exists. People who are pregnant with a substance use disorder legitimately fear going to the doctor. And one of the things they fear is the disclosure of information, and information that doesn't stay within the confines of the clinic, but that information that is then flows from clinical care settings to carceral settings, and information that can be used then to really criminalize their adverse pregnancy outcome, their having an infant who was substance exposed or something like that. So though in the ideal world, I would like to think that care is protective and beneficial to people, in reality, unfortunately, it isn't always. So another misconception is that people who are pregnant or parenting who use drugs don't care about the health or well-being of their fetus or of their infant. And in my experience of taking care of thousands, probably, of pregnant people with a substance use disorder over the past couple decades, I've yet to meet a patient who did not care for her health and well-being, as well as that of her baby-to-be or her infant. And overwhelmingly, my experience is not unique as a clinician in this space. Overwhelmingly, people, when they get access to person-centered and evidence-based care, they do really well. Almost every patient I've taken care of, not everyone, but almost everyone has, was stabilized successfully, during pregnancy. And if we could provide the continuing care postpartum, continued, stable in recovery. And I think the people with return to use and severe recurrence and stuff like that are actually much more the exception than the rule within our clinical care environment.